My name is Amy Doneen, and I'm an advanced registered nurse practitioner. And my role is I run the Heart Attack and Stroke Prevention Center in Spokane, Washington. And I am one of 2 members of the Bale Doneen method. And our method is 100% dedicated to the wall of the artery. Arteriology is our specialty. And our whole goal and our whole focus is to prevent heart attacks and strokes by focusing on a disease treatment paradigm versus a risk factor paradigm. Part of the problem is the current system is really based on risk factors. So we are either offered treatment for our risk based on our risk profile. So we take our age, the current system takes our age, our gender, our smoking status, our cholesterol, our blood pressure, and we throw it into a calculation. And based on our calculated risk, over a certain time frame, let's say 10 years, we're either offered treatment for that risk or we're withheld treatment based on that risk. The problem is that the threat of an event is due to the fact of either having or not having disease in the arterial wall. So if we as clinicians can do a better job by appreciating the risk factor burden, but looking for disease in our individual patients. And then if we find disease in our patients, we can find out why the disease is there. If we treat the why, we can see the inflammation go down and we can see the disease stabilize. So it's a pretty calculated opportunity to assess patients more appropriately than just relying on risk factors alone. Inflammation can be a systemic process that has local ramifications. So if we have plaque in the artery wall, we can that plaque can become stable if we treat it appropriately. And the threat of having an event really is the opportunity for that plaque to rupture through the artery wall, and the body's autoimmune response to a plaque rupture is to heal it. If we cut ourselves, we're going to heal it with a blood clot. So if the plaque ruptures through the artery wall and we have a injury to that artery wall, the body says, aha, let's heal this, and we end up with a thrombus or a blood clot that inevitably is going to block the flow of blood somewhere. And if the flow of blood is blocked in the heart, we'll call it a heart attack. If it's blocked in the brain, we'll call it an ischemic stroke. So the goal here is really to identify plaque in the artery wall well before there's a plaque rupture and a subsequent clot. So inflammation is really the catalyst that allows that plaque to rupture. And so many things can cause vascular inflammation. Cholesterol plays a role in inflammation. Oxidation of the bad cholesterol can create inflammation. Periodontal disease can cause vascular inflammation. Things like rheumatoid arthritis is a systemic inflammatory condition. Lots of things we deal with systemically can affect the arteries in a negative way because of inflammation, which is really the kingpin really of tying our bodies together as far as placing us at risk for an event or not. Plaque in the artery wall develops. It's a process. It's a progressive change of the dynamic within the artery wall. So we get fatty streaks that can develop in the artery wall. We get plaque deposition. We get creation of different cell bodies that create cholesterol plaques in the artery wall. Over time, those plaques begin to heal. And calcification is formed on those plaques. Calcification can occur if we treat the atherosclerosis, so we'll get calcification of the plaque. And it may sound odd, but having calcified plaque is safer than having uncalcified inflammatory plaque. So certain tests offer the technology to find the calcification, and certain tests also allow us to find plaque that is not calcified. So we have the technology now in current practice to find, yes, the calcified lesions and the uncalcified lesions as well. Is it normal to have calcification at a certain age in our life? So if we're 60 years old, is it acceptable to say, well, we have a little bit of heart disease or we have a little bit of calcium? Actually not. As I mentioned before, it is insanely common. It is the most common disease in every country that we have, that heart disease does exist. However, it's not a normal pathology of aging. If we find it, we need to find out why, and we need to treat the why. The other question and the other point is it progressive? Does the disease continue? It will if it's not treated appropriately, and that's part of the problem we have is the recidivism rate of heart attacks in the United States, and I believe in Ireland as well, is really dramatically terrible. People who have a stent often are back needing another one in a few years. People who've had even bypass surgery sometimes need stenting of those vessels that were bypassed. That doesn't have to happen if we do our job as clinicians appropriately and step back and say, well, if you have plaque, if you've had a stent, if you have any evidence of atherosclerosis in the artery wall, we need to stand back and say what caused it. What caused it? And if we can identify the why, the actual root cause of why someone has vascular disease, and we treat the why appropriately, then we can stop it. But unless we find out the why, yes, it is a progressive disease. My partner and I, Dr. Bradley Bale, identify people in a different way. We take an individual and we assess them for the presence of atherosclerosis. We are then going to do our due diligence to look for disease. We'll look in the artery wall of the neck. We'll look at the coronary calcification. We'll look at the aorta. We'll look at the arteries of the legs. We'll do our due diligence to look for atherosclerosis in the artery wall. If we don't find it, then we've just identified somebody truly in primary prevention. So the goal of treatment then becomes to never let plaque develop, right? That's ideal. That's true prevention. Secondary prevention are individuals where we have found plaque somewhere. In the case of Mr. Bobbitt, where he was fortunate enough to have a coronary calcium scan, which showed the presence of calcification in the arteries around his heart. However, he's never had a heart attack, correct? He's never had an ischemic stroke or an ischemic event anywhere. He is secondary prevention. The goal of secondary prevention is to never, ever let that plaque rupture, and for Mr. Bobbitt to have a clot to tell us that he's had plaque there for quite a long time. That's secondary prevention. Tertiary prevention are individuals we would identify who've already had an event. They've had something catastrophic happen, and our goal is to stop the recidivism associated with that event. So we never want to let them have another plaque rupture and a subsequent thrombus. So when we talk about treatment decisions, it becomes very easy when we identify people in those three categories. Somebody who's identified to be in secondary prevention, somebody who has calcification in the arteries around their heart, or who has plaque identified in the wall of their carotid artery, they are going to require certain medical treatments, even with the optimal lifestyle on board. So someone with plaque in the artery wall requires statin therapy, for instance. Statins are the best anti-inflammatory drug class we have for the wall of the artery. They reduce heart attacks by about 30 to 35%. However, to assume that's all they need would be inappropriate as well, because we still have a 70% residual risk left out there. So the goal is to, yes, apply certain therapies that are necessary in the presence of plaque, and to go beyond that and then ask the question, why is it there? The why question then demands often other therapies that are needed, sometimes niacin, vitamin B3. Sometimes it's a vitamin D deficiency that we need to address. We need to regulate nitric oxide to the artery wall, so we help to stabilize that artery wall so the plaque can't rupture. So different medication classes are utilized in that decision. For people who are secondary prevention, we take that opportunity to say, hey, can we identify your children early enough and forever keep them in a primary prevention standpoint? Meaning, let's never, ever let plaque develop in their artery wall, and that is possible. The challenge is people die of a heart attack or stroke, and then we assume that that's a statistic, and it goes to the certain, health department as a statistic regarding someone had a fatal heart attack. And yet, we should use that opportunity to say, what about the descendants of that individual, and can we look at them then a little bit differently in the standard of care and change how they're assessed forever, and try to keep them in that primary prevention. That's what will really start to save this country from a financial bankruptcy from the current system, which just throws all kinds of resources at treating end-stage disease. Mm-hmm. Why do some people who have significantly elevated cholesterol numbers never have a heart attack? Why is that? Believe it or not, LDL cholesterol, which is the bad cholesterol, which gains most of our focus, has never been independently predictive of who's going to go on and have a heart attack. Believe it or not. The treatment of plaque has been statin therapy, and statins happen to make LDL cholesterol look really pretty. So LDL cholesterol has been given by default all the credit for the value of the medication. However, LDL cholesterol in and of itself has not been predictive of heart attacks. When you look at cholesterol numbers, whether you're male or female, the most predictive is really taking all of the cholesterol, the total cholesterol, and dividing it by the good. So you get a ratio, the total cholesterol divided by the good cholesterol, called HDL. That ratio is predictive as far as event occurrence for both men and women. So it's a bigger picture. The cholesterol is important, but it's not the whole story. So yes, there are people that have high cholesterol that will not have an event, and there are people, and this is the scary part, who have excellent cholesterol and have their whole life been silently developing fatty streaks, plaque deposition in the artery wall. However, the reverse discrimination is you're thin, you're healthy, you're fit, you have okay cholesterol, so you must be fine. And that's a really scary population, because those are the people that go on and have an event, and we all scratch our heads and say, how did that happen? How did we miss them? And we miss them because the risk factors we assess don't always tell the whole story. If someone's diagnosed with coronary artery disease because they have a positive calcium score, there's nothing better than finding that you have plaque on a piece of paper, right? The other option is you have an event to tell us that plaque's been there for a long time. If we find plaque based on a coronary calcium score or a carotid IMT test, we've just opened a door and treatment opportunities that we can say, aha, we have found this disease. We have found it. It's never caused an event. Let's find out why you have it now. Let's embrace the value of genetics. Let's embrace the value of testing. Find out why that person has a positive calcium score. Treat that why and see that plaque start to stabilize and stop the progression of the disease. So having plaque found on a calcium score or on a carotid test is not a death sentence. It basically opens the door and provides education opportunities to stand back and find out why and treat that plaque appropriately so that events never occur. Women have less heart attacks, so we must be okay. The problem is more women have fatal heart attacks than men. Part of the challenge is women are harder to pick up for many reasons. One, we tend to present later to the emergency room when we have symptoms. We have a million things on our plate. We're mothers, we're caring for our family, and so we tend to put symptoms off. That's one problem. The pure size of our arteries are different. Our heart muscle is different. It can take less of an assault sometimes. The risk factors that we standardly look at may or may not depict our risk appropriately. We have hormonal issues that vary based on our age and our menopausal situation and so forth. So women, although by true numbers may have less events, the reality is the current system does not do a very good job on picking us up at an earlier age for the presence of atherosclerosis. There's a reverse discrimination that if we're female, we certainly can't have heart disease, and that's just simply not true. It's simply not true. Heart disease has been diagnosed when someone has a heart attack, and so we are geared to treat end-stage disease. That means we throw all kinds of resources and energy at opening up an artery once it's blocked with a thrombus. And so the attention has been treating these events that occur. An event is really a nice name for a plaque rupture and a subsequent thrombus. The reality is, though, if we open up one small area of a systemic problem, and we don't stand back and treat the systemic disease, then that end-stage event is going to occur again. So we sort of chase ourselves in the current standard as it's set up in the United States anyway, to just go in and rescue one small part of a 60,000-mile vessel system. And so if we can turn our focus on the cause of vascular disease, treat the cause, and stop the inflammation associated with the disease, we have a far better opportunity to prevent an event from ever happening. And an event, really, keep in mind, can be a heart attack, can be an ischemic stroke, can be vascular dementia, can be end-stage kidney disease. All of these things affect our life quality and our life expectancy. And so we need to realize that atherosclerosis, 1, is preventable, 2, is treatable, and 3, we can live a long and healthy life with plaque embedded in our artery wall as long as it stays there. We use statin therapy to stabilize that plaque. Certainly it's an anti-inflammatory agent for the wall of the artery. But there's other treatments out there that go beyond just the value of statin therapy. We need to get that 70% of residual risk treated. So there's a lot of opportunities to utilize other options such as vitamin B3, which is niacin, which helps the good cholesterol, which is very vital as far as plaque stabilization. Vitamin D deficiency is horribly common in the United States, and I believe in Ireland as well. Many people are deficient in vitamin D3, and so we supplement vitamin D3 levels to get to appropriate levels to show vascular wellness. Other things, believe it or not, like dark chocolate can affect blood pressure in a favorable way. Not all pills are hard to swallow, right? Dark chocolate at 72% or higher at 7 grams per day actually lowers blood pressure and reduces stroke risk by about 49%. Can't go wrong with that. Cinnamon at 2 grams a day also helps with blood sugar regulation. So lots of things that are out there that the public needs to be aware does have strong scientific data to support that we may want to supplement our current diet. Nothing beats, though, by the way, a good, healthy, nutritious diet. We can supplement if we need to, but the best way to get nutrients is by making sure we have enough good whole foods in our diet. Diabetes is the fastest growing disease state that we have. It's hitting people young, and it's an aggressive problem. When we look at the root causes of heart disease, insulin resistance claims responsibility for about 70% of plaque development in the artery wall. Diabetes is considered a coronary risk equivalent. That is, if we are diagnosed with diabetes, we are treated the same way as if we just had a heart attack. The challenge to us clinically is to identify that 20 years prior to a diabetic situation. In other words, identifying pre-diabetic individuals. If we can identify someone in a pre-diabetic state or an insulin-resistant state, just like with heart disease, we can stop the progression of that disease state, and we can actually even prevent diabetes, and which is a huge opportunity. In the United States, we have a major problem with adolescents getting type 2 diabetes. Obesity is becoming more and more of a problem. Different things like smoking, lack of sleep also propel our risk. Genetics carry a risk. And what we need to do in the current system is identify people for insulin resistance, and that can be done very effectively rather than waiting until they have diabetes. One of the best ways to cause a revolution, which is really needed right now, we need to do something different, is to educate the public. So the goal of David's documentary that we're doing now is really to educate the public and arm them with the information they need to realize that you can go in and you can ask for these types of tests. You can ask for a coronary scan. You can ask for carotid IMT. It's appropriate to ask why. Right? It's appropriate. It's appropriate also to interview your medical provider. Why wouldn't you, right? You're asking for advice. Interview them and make sure that they're savvy on the current research and the information out there. So a revolution is going to take the public education forefront to really make that happen.